Right. Okay. So let's start. Fine. So today's session and the subsequent 5 sessions that we're going to have are going to focus on each system. Okay. And as I told you yesterday, we'll have 2 sessions for the neurological examination because it's a bit more complicated than the other systems. And it takes a little bit more time for you to understand it. Right. Now, today we are going to talk about the cardiovascular system. Now, the discussion today is in 2 parts. The first part, which we'll do rather quickly, is just to revise the technique of examination. Okay, I know that you've already done this, but I also know that you don't remember any bloody thing about it. So we will just revise that so that when you go for your second appointments, you will have a fresh mind and you'll be able to practice these techniques. So the first section is going to be on techniques and the proper method of examination. The second part of the discussion is something which is rather new to you, and that is about the physical signs and how to interpret these physical signs in relation to the cardiovascular system. So let's start off. Any questions again you have, just post it on the group. Make sure that you make the questions visible to everybody so that everybody knows the question and I can answer that at points during this discussion. Fine. Hi. Now, basically, talking about the examination technique, any examination technique commences, or the routine or method commences with a proper introduction and an explanation of the procedure to the patient. Now, this is very important, and even though you do this every single day, it is still important. Okay? And sometimes you forget this, especially at the exam. Make an exam in your routine clinical practice also, make sure that you introduce who you are and you explain the procedure, what's going to happen to the patient, okay, during your examination. The next thing is you need to ensure proper positioning and adequate exposure. Now, for example, cardiovascular systems examination should be done with the patient propped up at 45 degrees, okay, as is the respiratory system examination, okay. Adequate exposure is important, right? And this is especially true for the abdominal examination, where you have to ensure adequate exposure. Then what you do is you stand back and perform a quick visual inspection of the patient. And there are certain physical signs that will be obvious just by looking at the patient. So therefore, this inspection is very important, just a scan of the patient to see whether you can spot any obvious clues. And also look around the patient, not only at the patient, because there may be clues in the surroundings as well. Right. Then you do a quick general examination. Now, the general examination should be focused for things that will give you information with regard to the cardiovascular system. Okay. For example, things like clubbing, peripheral stigmata of infective endocarditis, and ankle edema. And in your general sort of inspection, you'll also be able to see things like neck pulsations, which may be very, very obvious. Right. So just a quick overview of what you do before you go near the patient. Just a quick screening, evaluation, and a general examination. Right. Now, very important in the general examination, the proper technique for clubbing or in looking for clubbing. On the right-hand side of the slide, I have given you a picture on the proper way how to look for clubbing. And remember, the hand of the patient should be at your eye level when you inspect clubbing. Okay. Make sure that you keep your eyes level with the patient's hands when you're doing this. And what you're checking for is the angle between the nail fold and the nail. Right. And obviously, clubbing can be graded. And this is given in the slide. I'm not going to read out what is there on the slide. This is for your reference and your notes. So I've included a little bit more of sort of text on the slide so that you can use this for studying purposes as well. Okay. And basically, you're looking for, there are various grades of clubbing that you need to understand. Now, the reasons for clubbing are different, and there are many theories about this. And there are theories that certain growth factors like vascular endothelial growth factor and platelet-derived growth factor, as well as something called hypoxia-inducible factor, or HIF, right? Which is a factor which is secreted in hypoxia. And for your information, this was awarded the Nobel Prize last year in medicine. The person who discovered this, and is incidentally one of the people who you meet in the canteen at Oxford. He's one of the consultants in Oxford and one of the professors at Oxford. So I've seen this chap in the canteen. So it's obvious you see Nobel Prize winners in the canteen in Oxford. It's quite interesting in that sense. So basically, pathogenesis of clubbing could be due to these types of growth factors and expression of these growth factors. But very important, remember the technique of clubbing is very important, how to look for clubbing. Okay, moving on. Ankle edema. Again, in the picture, I've given you the right place where to look for ankle edema, right? It is just above the medial malleolus, and make sure that you keep sustained pressure for a time period of 10 seconds, okay? Keep sustained pressure over the bony prominence just above the medial malleolus for 10 seconds, then raise your finger and then look for indentation or depression in this area, and that is called pitting, okay? Fine, and that is how you look for ankle edema. So remember to follow the proper technique. Tappara 10 kiyane tappara 10. 10 seconds means 10 seconds, and don't take shortcuts. These are important principles of examination. Right. Now, once you do this general examination, we go to the cardiovascular system proper. Okay. Now, when you're doing the cardiovascular system proper, you have two components. So it's easy to think of it or remember it in that way. You have the pulse examination on one hand, and then you have the precordial examination. And in between the two, you also have blood pressure measurement, which you have to routinely do, but not really at the exam. So when you're routinely doing the cardiovascular system in the wards, you have to check the blood pressure. But at the exam, we generally tell you the blood pressure if you ask for it. Okay. So generally, these are the two broad components, or the pulse examination and the precordial examination plus the blood pressure measurement. Okay. The pulse examination can be divided into two further components: arterial pulse examination and venous pulse examination. Okay. And I have just listed, and all of you know this, I'm just revising this for your benefit. In the arterial pulse examination, you look for rate, rhythm, character, specifically examine for collapsing pulse, then look for radioradial and radiofemoral delay. So that is the arterial pulse examination. Then you have the venous pulse examination. So arterial pulse examination, venous pulse examination. These are the components of the pulse examination. Make sure that you examine the arterial pulse in the proper manner and look at the picture. Okay. So it's the patient's hand should be flexed at the wrist, as you can see me holding with both hands. These are very important. These are just basic principles. The moment you touch the patient, we know how experienced you are in examination. So the wrist is slightly flexed, right? And make sure that you feel the pulse with 3 fingers. And I think I have taught you during your introductory appointments why this is important, why you're feeling it with 3 fingers. If you don't remember, please try to find out. Okay, so wrist slightly flexed and you feel the radial pulse with 3 fingers. So very important. These pictures also you can take. Don't put these on the internet or anything, for your personal use, to remind you of the critical techniques when you're examining the cardiovascular system. I am give you pictures for all the systems as well. Like a video is important because I have only given you pictures of the most important techniques. So remember this. Fine. Moving on. This is the proper way to examine the collapsing pulse, and look at the way my hands are positioned. Okay. You can see my left hand with my thumb on the brachial pulse, and the right hand with the palm of my hand, that is the metacarpal regions of the palm should be touching the radial artery. Okay. And then with one swift movement, single movement, you lift the hand off the bed. Okay, lift the arm off the bed. Okay, so make sure the position of your 2 hands are important. Okay, so one finger should be on the brachial artery pulse, the other hand should be on the radial pulse, and the metacarpal bones, or at least the palmar surface, should be touching the radial pulse. Okay, to a point where you can just lightly feel the pulse. Okay, and then you lift it with one important, that you lift it with a single movement, and make sure that you don't, and write this down very clearly, don't change the pressure at these 2 points. So the 2 points that you're holding are the brachial pulse and the radial pulse. Don't change the pressure at these points. Using one single movement, just raise the upper limb off the bed. Okay, so make sure, watch this picture again. The two positions I'm keeping my hands on, and the important thing is one single movement. Don't change the pressure at the radial area or on the brachial pulse. And if the patient has a collapsing pulse, when you raise the upper limb, you will feel a very strong pulse at both of these areas, at the radial area as well as the brachial area. At those two areas, you will feel a very strong, prominent pulsation. Right. So collapsing pulse, frequently when people come for the exam, we have seen in wards, you don't do this very well. So make sure that you follow these steps. Keep your hands in the proper way. Use one single movement. Don't change the pressure at the radial area and the brachial area. Good. So let's move on. And this is the final step, as I told you. Raise it 90 degrees to the bed. Okay. And again, I emphasize, don't change the pressure at these two areas. Okay. Same pressure that you were holding in the previous position, in the resting position. You lift it up to 90 degrees, and then don't change the pressure at these 2 points. The 2 points would be the hand over the radial pulse and the finger over the brachial pulse. And you will feel a very prominent pulsation if the patient has a collapsing pulse. Right. So that's the radial pulse. So rate, rhythm, character, and collapsing pulse. This is the proper technique of how to feel the carotid pulse, usually with the thumb slightly upwards and lateral from the thyroid eminence. Okay, somewhere there. All of you know this, just for revision. Then this is the radio-radial. You're looking for radio-radial delay. And this is looking for radio-femoral delay. Now, when you're doing the examination, as well as at the exam, you have to expose the femoral artery. Never do it over the clothes like I'm showing here, which is a wrong technique. But I didn't want to expose this patient because this is going to be used for educational material. Patient was not willing to be exposed. So that's why I'm using my fingers over the trousers. But remember, at the exam, make sure you expose the patient's femoral artery when you're doing the radiofemoral. Poddak kalisama pahat karla etana hold the pulse there. Okay? Fine. So radiofemoral delay. And you know that radio-radial and radiofemoral delay can occur in certain conditions, which we'll discuss in a while. So arterial pulse examination completed with the examination of the peripheral pulses. Okay, dorsalis pedis and posterior tibial, which I have shown in these pictures. Dorsalis pedis pulse. Look at the surface marking of the pulse using this picture. Okay, it's right between these two tendons. You can see the tendon going to the big toe and the tendon going to the second toe. If the place, the depression in between these things at the dorsum of the foot is where you get the dorsalis pedis pulse, and there you get the posterior tibial pulse. Fine. So that's the arterial pulse. So you examine the arterial pulse looking for the rate, right? The rhythm. Okay. Examine for radio-radial delay, radio-femoral delay, collapsing pulse. So there we go. And then look at the peripheral pulses, especially the dorsalis pedis and posterior tibial. Okay. I hope this is a good revision for you because you already know these. Pictures important. Don't share these, please. Don't put this on any sort of common sites. It's just for use for your batch. Okay. Right. Jugular venous pressure is difficult to assess for a medical student. And we don't expect you to measure the jugular venous pressure in your clinical evaluation. Okay. But you should be able to look for two things. Okay. One is you need to differentiate the jugular venous pressure from a carotid pulse. Okay. Now, sometimes you will see in the neck several pulsations. So that are pulsations. And you should know how to differentiate the jugular venous pulse from a carotid pulse. And there are many ways on how to do that. Okay. And obviously, the easiest thing to look for is the palpability of the pulse. If it's a carotid pulse, you can palpate it. That's one way of differentiating. And the second thing is compressibility. You can compress and get rid of the jugular venous pulse, but you can't do that for the carotid pulse. Okay. So look for palpability and compressibility. Okay. And that's easy how you differentiate the jugular venous pulse from the carotid pulse. There are some other things, just read that later. Blood pressure, I told you, you can ask the examiner. In a ward setting, you have to examine this for yourself, but at the exam, we will give you the blood pressure reading. Okay? All right. Sorry. So that is the first part of your cardiovascular system examination. Okay? Where we did a general examination, general impression, went to the pulse examination. In the pulse examination, we had an arterial pulse examination and a venous pulse examination. Arterial pulse examination, starting with the radial pulse, techniques are important. Where you hold your hand, patient's hand is important. Rate, rhythm, character, the proper technique of collapsing pulse I have shown you, and then radio-radial, radio-femoral delay, other pulses like carotid pulse, dorsalis pedis, and posterior pulses. And then we went on to the jugular venous pressure and then the blood pressure measurement. Then we move on to the precordial examination. And the precordial examination consists of 3 steps: inspection, palpation, and auscultation. Again, you know all of this. Inspection, I have given you a list of things that you look for. Chest wall deformities, visual pulsation, surgical scars, for example. Inspection. Palpation, important thing to do is first locate the apex beat and describe the character. And this is how you locate the apex beat. You use 3, now watch this very carefully, use 3 fingers to get a rough idea of where the pulse, the apical pulse is. Again, write down very clearly, I think I might have taught this to you before as well. The apex beat means the most lateral, that is the most lateral and inferior point where you can feel the cardiac impulse. I repeat that. The definition of the apex beat is the most inferior and lateral point where you can feel the cardiac impulse. Right? හොඳටම දැනෙන්න තැන නෙවෙයි. It is not the best place where you can feel. It is the most inferior and lateral point where you can feel the cardiac impulse. Use 3 fingers to get a rough idea of where the apex beat is located and then localize it to your middle finger. Okay, so use 3 fingers first like that and then finally locate it with your middle finger. And then using 2 points, you will describe the location. One, as you already know, is the mid-clavicular line. Okay, mid-clavicular line. And then the other one is go from the sternal, sternal angle and count the rib spaces. So you know that the intercostal space corresponding to that would be the second intercostal space. Count down and locate the apex beat. Okay, so 3 fingers first localize it and then try to be precise, put it onto your middle finger and then count along the mid-clavicular line and get the rib spaces by going through the sternal angle, which corresponds to the second intercostal space. So describe the location and the character of the apex beat. Now there are various characters of apex beats. One is called a tapping apex. We'll talk about this in a little while as well. Tapping apex is simply, you can feel a heart sound. It's a palpable heart sound, palpable first heart sound in the apex. And that is what you call a tapping apex, a palpable first heart sound in the apex. Then you have a thrusting apex. I will show what it looks like. So a thrusting apex is a very forceful but non-sustained. So write this down. It is a non-sustained apical impulse. Very forceful but non-sustained. That's a thrusting apex. And always remember that a thrusting apex is usually displaced from the normal position. Okay. So thrusting apex simply means a very forceful but displaced apical impulse. Okay. That impulse is usually displaced from the usual position. Then you have a heaving apex, which is a sustained, forceful apex. You can see the difference. Thrusting, heaving. Okay. Heaving. So that's a heaving. This is a thrusting. And this is a heaving. So the heaving apex is a forceful but sustained apical impulse. It is a sustained. Word is important. It is a sustained apical impulse. Okay. And usually this heaving apex is a non-displaced apex. It usually is in the same position. Okay. It is not displaced or deviated. Okay. So going back to the principles then of palpation, locate the apex beat, describe the character. Okay. Character would be normal, tapping apex, thrusting apex, which is a forceful but non-sustained apical impulse, which is usually displaced. Heaving apex, which is a forceful sustained impulse, which is usually non-displaced. Okay, fine. Then you feel for thrills, Lamai. Okay, this is, I have shown you how to locate or count the position of the apical impulse, right? Look at these pictures there. Mid-clavicular line. Fine. Now what I'm doing is, you can next feel for thrills. So thrills can be felt in the major auscultatory areas: apex, lower sternal edge, upper sternal edge on the left side, and upper sternal edge on the right side. So as you know, there are 4 main auscultatory areas. If you don't know, please write this down. You should know, obviously, because you've already done your first appointment. So apex would be one area, left lower sternal edge would be another area, left upper sternal edge would be another area, and the right upper sternal edge would be another area. So just feel in these areas for thrills. Thrills exactly are like just a flow of water under your palm. You will feel it like a gush of water running under your palm. Okay. In this picture, I have shown you how to examine for a parasternal heave. Parasternal heave basically means a palpable impulse, cardiac impulse along the left sternal edge. Okay. So in your palpation, thrills would be next, and then parasternal heave is just a palpable cardiac impulse along the left sternal border. This indicates right ventricular hypertrophy. What the meaning of it is, the left parasternal heave indicates hypertrophy of the right ventricle, because that is anatomically what underlies this area. Okay. And then finally, feel for a palpable second heart sound, like I have shown in this picture, in the pulmonary area. So you are feeling for a palpable second heart sound in the pulmonary area. Now the last, palpation is very easy. Palpation, you're focusing on the apex beat, counting the position of the apex beat, and then also commenting about the characters, tapping, thrusting, or heaving. Then you went on to palpate all the major auscultatory areas for thrills. Okay. And then feel in the pulmonary area, which is basically the left upper sternal edge, for a palpable second heart sound. A palpable second heart sound will indicate pulmonary hypertension. Okay. And then parasternal heave, I have shown you how to do. So these are the techniques of palpation. Auscultation is very simple. You listen in the auscultatory areas. Remember that you start off the auscultation, and sorry, my tie is in the way, but you look for auscultation starting with the mitral area with the bell of the stethoscope in the left lateral position. Okay, turn the patient to the left lateral position, and this patient is at the left lateral position. Right, it would be very obvious from this picture, but listen using the bell of the stethoscope. And then diaphragm in the major auscultatory area. So apex, left lower sternal edge, left upper sternal edge, and right upper sternal edge. Also, you can auscultate over the carotid. Okay, and you might hear bruit. Bruit is basically a murmur over a vessel. Okay, it is simply described as a murmur over a vessel. And at the end, Lamai, make sure that you ask the patient to sit up, lean forward, hold the breath in expiration. So what are we going to do? Sit up, lean forward, hold the breath in expiration. Okay? So husma gannawa, pita karnawa, husma gannathu inna. Don't ask the patient to forcibly hold the breath, because that is something different that happens then. Just up, down, and stop breathing. Not forcefully hold. It's just up, down, and hold, and then breathe again. So patient leaning forward, breath held in expiration, and listen over the left sternal edge. Why you do this is the best position to hear the murmur of aortic regurgitation. We will discuss that in a little while again, but this is the best position to hear the murmur of aortic regurgitation. Patient sat up, leaning forward, and breath held in expiration. And finally, okay, if you hear a murmur in your auscultation, make sure that you, and write this down, or you obviously have these slides at the end, you have to comment on these 5 points when you hear a murmur, or at least note these 5 points. Number 1, where the murmur is best heard. Now this is very, very important. Underline the word best heard. Because some murmurs you can hear all over the place, right? You can hear it all over the place. But that's not what we are interested in. We are interested in where the murmur is best heard. So make a note of that. Time the murmur, systole or diastole. And I think I might have told this to you, but again for revision, the timing is if the murmur comes with the pulse, and you time it always with the carotid pulse. If a murmur corresponds with the carotid pulse, that is a systolic murmur. If the murmur and the pulse come separately, that is a diastolic murmur. So the easy way to do it, right? Systolic, pulse and murmur come together at the same time. Diastolic murmur, pulse and murmur come separately. So that is diastole, timing of the murmur. Third thing is radiation. What does radiation mean? Radiation means that you can hear the murmur in the same intensity in another area. Okay, underline the word same intensity. You can hear the murmur in the same intensity in another area. Okay, other features, right? There might be certain other features. For example, the character of the murmur, right? Rumbling, blowing, tearing. There are various words that we use. Crescendo, decrescendo. So these could be other features or the character. You can also call it the character of the murmur, right? And then finally, dynamic maneuvers which increase or decrease the intensity. Some murmurs, especially murmurs arising from the right heart, increase with inspiration because the venous return to the heart is increased. Okay. So inspiration, expiration, these are dynamic maneuvers. Valsalva maneuver is a dynamic maneuver. We don't usually do that. It has a use in a certain condition, but we don't often do that. Exercise can be dynamic maneuver where sometimes some murmurs get, the sound gets louder when people exercise. So there are dynamic maneuvers which increase the intensity of murmurs. Right? So these are the characteristics that you have to note when you hear a murmur. Area that is best heard, again highlighting the word best. Timing of the murmur, whether it's systolic or diastolic. Radiation, whether it can be heard in another area in the same intensity. Other features like the characters, tapping or blowing or whatever, rumbling. Dynamic maneuvers could be inspiration, expiration, or Valsalva, for example. Okay, so that is the first part of this discussion where we talked about physical examination technique. So just to revise what we have discussed, we talked about the cardiovascular system examination. And please post any questions if you have any questions from the technique, anything that you might have learned in your first appointment you found a bit confusing, where what we taught in the department and what somebody else taught might be contradictory. All these things you can ask and I will clarify them for you. But make sure you post it for the entire group to see. Right? Okay. So then, so you start off with a general examination, impression, okay? And then you move on to the cardiovascular system proper, which is pulse examination, blood pressure examination, and precordial examination. Pulse examination is arterial pulse and venous pulse examination. Arterial pulse examination is rate, rhythm, character, collapsing pulse, radioradial, radiofemoral delay, and peripheral pulses and other pulses. Jugular venous pressure, just to identify the jugular venous pressure, is adequate. Okay, moving on, then we go on to the blood pressure and then the precordial examination. Precordial examination is inspection, palpation, auscultation. Palpation is apex beat, feeling for thrills, parasternal heave, and second heart sound. Okay, palpable second heart sound. Auscultation, listen in the auscultatory areas in the maneuvers that I described, starting with the left lateral position with the bell, ending with the patient bending forward and breath held in expiration. Right? And for a moment, you have to talk about the look where it is best heard, whether it's a systolic or diastolic, other characteristics, radiation, and also whether there are any dynamic maneuvers, for example, inspiration, expiration, that increase or decrease the intensity of the. Okay. Sachit, could you explain the difference between collapsing pulse and bounding pulse? So, collapsing pulse basically is when you elicit the pulse in that way that I showed you, okay, the pulse gets more prominent. A bounding pulse just refers to a high volume pulse. And yes, as I forgot maybe to mention that you have to mention the pulse volume as well. Remember that the pulse volume is best assessed in the central pulses like the carotid pulse. Okay, Chandu. In PEEP, some people say look for dextrocardia with both hands. In medicine, I don't think that's really necessary because it will be really cruel for us to give you a dextrocardia patient. Sanjay. So could you tell a little bit more difference between tapping and thrusting? So tapping is a very localized cardiac impulse. Okay, it's a very localized and you can feel it like a, it's basically like a palpable heart sound. Okay, dap dap wage, you can feel it onto your palm. A thrusting apex is basically a more forceful apical impulse. You can feel the apex there, like the cardiac muscle coming and hitting your hand, and it is a very forceful and non-sustained. So it just goes and heaving apex is forceful, but it is sustained, sort of pushes your hand up. Pikum, so is it necessary to auscultate lung base and live in every case? No, it's only if you have time. This is at the exam, only if you have time. In the ward, you will be doing this anyway, because you're doing all the systems. But in a short case, if you have time only, you can look for the lung bases and the liver, because these are features of heart failure. Purna. Do you need to look for collapsing pulse only in high volume pulse? Ideally, yes, Purna. If you detect a normal or high volume pulse, that's when you look for collapsing pulse. It will be obviously silly to look for collapsing pulse if you can't feel the pulses and the pulses are low volume and just barely palpable. So that's a good observation. Hi. So shall we move on then? Now we come to interpretation of physical signs. Okay. Now this is something which has not been taught to you. It should have been taught at some point in your modules, but I know that it hasn't. So that we'll go through this now. How do you interpret physical signs? Now, in the general examination, the key thing to look out for is cyanosis. Okay, and cyanosis is basically a dusky bluish to purple discoloration of the mucous membranes and the tongue. Okay, central cyanosis is far more important than peripheral cyanosis because central cyanosis indicates deoxygenated blood in the arterial circulation, and you find cyanosis in right to left shunts. Clubbing is very important for cardiovascular system, and clubbing is seen in cyanotic heart diseases. Okay, clearly you see clubbing in every cyanotic heart disease. You also see clubbing in infective endocarditis, but usually the clubbing in endocarditis is mild. In cyanotic heart disease, you get really obvious pata clubbing. Okay, but in infective endocarditis, because it's a more acute process, it's only mild clubbing, so you have to be careful not to miss it. And for your information, clubbing is also seen in another cardiovascular condition called atrial myxoma, which you can write down. It's not on the slide. Atrial myxoma is a tumor in the atrium. It's a heart tumor. That also causes clubbing. And some of the manifestations of atrial myxoma are very similar to infective endocarditis. Right. In this patient, you can see, interesting to note that there is clubbing only in the toes, but not in the fingers. That's very clearly seen, either. Clubbing in the toes and not in the fingers. This is called differential clubbing. And it is seen in a very specific condition in a reversed patent ductus arteriosus. You see it in a reversed patent ductus arteriosus. Look at the picture on the bottom. Reversed PDA, there is a right to left shunt. If you follow the arrow here, you will see that. And now you can see that good blood, oxygenated blood is going to the hands through the subclavian artery. But deoxygenated blood is going now to the limbs. So the good blood is going to the hands to the subclavian artery. But because the PDA is causing a right to left shunt, it enters the lower limbs only, or sort of predominantly the lower limbs there. So you get clubbing in the lower limbs only. This is called differential clubbing. It's a bit of an interesting finding. Okay, it occurs in a reversal of a patent ductus arteriosus. Okay. Hari. Now, when you finish your examination of the cardiovascular system, you can diagnose several types of diseases. Okay. If I just list them out, please write this down. So basically you can identify for medicine, and these are important for your short cases as well in your final years. You have a certain list of things that you can diagnose with your cardiovascular examination. And this is undergraduate. One postgraduate kata karanne obvious reasons. Undergraduate. So you can diagnose Eisenmenger syndrome and tetralogy of Fallot very nicely through examination. Okay. But you cannot identify any of the other cyanotic heart diseases. Right? They are very difficult. You always need echoes to diagnose them. There are lots of other cyanotic heart diseases, but you can't examine them or diagnose them with examination alone. You need your investigations. But Eisenmenger syndrome and tetralogy of Fallot, you can very clearly diagnose. Right. You can also very clearly diagnose the valvular heart diseases. Okay, for undergraduate purposes, these would be mitral regurgitation, mitral stenosis, aortic regurgitation, aortic stenosis. Okay, and maybe tricuspid regurgitation also. I'll teach a little bit about that as well. ඔය ටික විතරයි. තව ඉතින් ඔය pulmonary regurgitation, pulmonary stenosis දෝ වගේ තියෙනවා. But ඔයගොල්ලන්ට undergraduates ලගේ we don't expect you to know how to diagnose. Okay, those are most postgraduate and actually very rare as well. Rare. I might have seen maximum of 2 pulmonary regurgitations in my life, or very clearly diagnosable ones, primary ones. That is. So, and pulmonary stenosis is a bit more rare as well. So, you don't need to know those. Fine. Then, you can also diagnose ASTs, BSTs in medicine. PDAs also, medicine and pediatrics, you'll get PDAs as well. Okay. So, these are the types of conditions that you can diagnose through physical examination. And now I'm going to teach you a method of diagnosing these conditions without auscultating the patient. Okay, it may sound really revolutionary or funny, but you can diagnose all of the conditions that I just mentioned. Eisenmenger-Toff, mitral tricuspid regurgitation, mitral stenosis, aortic stenosis, aortic regurgitation, AST and BST without using your stethoscope. Okay, and that is important. It's not difficult to do. It needs a little bit of practice, but it's not difficult to do. Auscultation we use just for confirmation. Okay, right. So let's start. Now clear your minds and make sure that you focus, because this is something that is gathered from a lot of sources and nobody else is going to teach you this. So listen very carefully. Right. Now when you examine the patient's cardiovascular system, you find cyanosis. Central cyanosis. Peripheral cyanosis, but if you find central cyanosis, you are really happy. Why are you really happy? Because in adult medicine, there are only 2 conditions the patient could have. Okay? You are exceptionally happy if this comes in your exam as well, because you have 50% chance of getting it right. Whereas the patient does not have cyanosis, you have about a 10% chance of getting it right, because there are lots of other conditions which are acyanotic. So if it's cyanosis, beautiful, you're wonderful, you're really, really happy. In adult medicine, cyanosis in the cardiovascular examination due to cardiovascular causes is due to 2 conditions. One of 2 conditions. Eisenmenger syndrome or tetralogy of Fallot. Eisenmenger syndrome. What is Eisenmenger syndrome? It is basically reverse shunting. Reverse shunting through a congenital heart defect. As you know, usually the shunting is left to right because of the pressure difference. But with time, what happens is, with time, the pulmonary pressure starts building up. The pulmonary pressure starts building up, and the right heart pressure goes up, and the shunt starts reversing. Starts going from right to left. And now you get a mixture of oxygenated blood with the deoxygenated blood. So, cyanosis occurs. So, cyanosis, one important cause of cyanosis in adult medicine is Eisenmenger syndrome. Eisenmenger syndrome, where there is reversal of a shunt. And this is due to pulmonary hypertension. Underline karagan, very important, because of the left to right shunt, right blood, the increase of blood to the right side ultimately results in pulmonary hypertension. And that's what causes the reversal ultimately. It starts reversing the other way. Because the right heart pressure is more than the left heart pressure now. So, pulmonary hypertension is the main problem in Eisenmenger syndrome. The other adult disease, or the one disease you can see in adults causing cyanosis, could be tetralogy of Fallot. Remember, patients with tetralogy of Fallot can survive to adulthood, even if they don't undergo intervention. They can survive. So, tetralogy of Fallot is another condition that can cause cyanosis. Now, if you remember your embryology and pediatrics, there are 4 cardinal issues, problems in tetralogy of Fallot. And the most important of them is pulmonary stenosis. Pulmonary stenosis. And you can see in this picture, pulmonary stenosis. Pulmonary stenosis. So you have a patient, you are doing the cardiovascular exam, you find cyanosis, you are really happy, because in adult, this could be only either Eisenmenger syndrome or tetralogy of Fallot. Even in pediatrics, ඔය දෙක තමයි තියෙන. තව ගොඩාක් එක ලෙඩ තිබ්බට ඒවා clinically diagnose කරන්න අමාරු. They are difficult to diagnose. So you have Eisenmenger syndrome and tetralogy of Fallot. The cardinal feature in Eisenmenger syndrome is a reversal of the shunt due to increasing build-up of pulmonary pressure, right? Pulmonary hypertension. There are 4 abnormalities in tetralogy of Fallot, where the cardinal problem is pulmonary stenosis. And then you have the other ones, VSD, overriding aorta, Rammanang, and right ventricular hypertrophy. Okay? But the key feature is pulmonary stenosis. Right. Now, how do you differentiate these two? Cyanose patient, is it Eisenmenger? Is it tetralogy of Fallot? How do you make that differentiation? I have told you the answer, Lamai. What is the main thing driving Eisenmenger? It is pulmonary hypertension. So the patient will have full-blown signs of pulmonary hypertension. Full-blown signs of pulmonary hypertension. Like elevated jugular venous pressure, number 1. Palpable second heart sound in the pulmonary area. And a parasternal heave because of right ventricular hypertrophy. Pulmonary hypertension causes hypertrophy of the right ventricle. So, in Eisenmenger syndrome, you have cyanosis with elevated JVP, palpable second heart sound, and a parasternal heave due to right ventricular hypertrophy. If you keep the stethoscope, you will hear the loud second heart sound. So if you find a patient with cyanose, you find elevated JVP, second heart sound palpable with parasternal heave. If you like, you can auscultate, but basically you have already diagnosed Eisenmenger syndrome in that patient. Murmur එකක් ඕනෙත් නැහැ. ඇහෙන්නෙත් නැහැ ගොඩක් වෙලාවට. Murmur එකක්. හරි. Tetralogy of Fallot is a completely different ball game. Why? What is the cardinal feature in tetralogy of Fallot? It is the pulmonary stenosis level. So pulmonary stenosis means low pulmonary blood flow. So they will never develop pulmonary hypertension. Never. Unless, of course, there is some intervention that has been done, which we won't talk about for the moment. So pure and simple tetralogy of Fallot, they will have pulmonary stenosis, and therefore they will not have features of pulmonary hypertension. A soft, impalpable second heart sound will be the feature there. I will also feel a thrill in the pulmonary area because of the stenosis. A thrill in the pulmonary area. Okay. So very simple. Because these two are opposing pathophysiological mechanisms, Eisenmenger syndrome is pulmonary hypertension driving everything, whereas tetralogy of Fallot is pulmonary stenosis and poor blood flow into the pulmonary artery. Therefore, loud second heart sound, palpable second heart sound, and right ventricular hypertrophy in Eisenmenger syndrome versus in tetralogy of Fallot, soft, impalpable second heart sound, but you will still get the parasternal lead because of the right ventricular hypertrophy. And you will have a thrill in the pulmonary area. Why do you get right ventricular hypertrophy in TOF? Because of the pulmonary stenosis, narrow valve එකක් තියෙනවා. But there will be no features of pulmonary hypertension. Very simple. So that's the first step in your algorithm. Okay. Cyanosis, both either Eisenmenger or tetralogy of Fallot. Signs of pulmonary hypertension plus Eisenmenger. Cyanosis without evidence of pulmonary hypertension. Tetralogy of Fallot. Simple as that. Hari. Moving on. Now, when it comes to acyanotic people, it's a bit more difficult because there are many other conditions. Mitral stenosis, mitral regurgitation, tricuspid regurgitation, aortic stenosis, aortic regurgitation, ASD, VSD. So you have about a 10 to 12% chance of getting it right if you guess. But again, it's easy. Let's go by each other steps. Remember, we are not going to use auscultation for this purpose. Fine. Pulse examination. We're going to take each component separately and try to diagnose these 6 or 7 conditions without using the stethoscope. Feel the pulse. It is irregularly irregular. What does that mean? irregular pulse means atrial fibrillation. Harida, atrial fibrillation. Atrial fibrillation means left atrium is dilated. Okay, and then this is almost always due to mitral stenosis. Okay, in our setting. Okay, so atrial fibrillation, there are a lot of other causes of atrial fibrillation, but in our setting, atrial fibrillation is most often due to mitral stenosis and also sometimes due to pure mitral regurgitation. So in other words, මොකද අපිට කියන්න වෙන්නේ? If we feel the pulse and find irregular pulse, we are very happy. Why? Because this patient is very likely to have mitral stenosis and less possible to have mitral regurgitation as well. දෙකම තියෙන්නත් පුළුවන්. So very important, write that down, mark that down. Irregular pulse, AF තියෙනවා නම් you are very likely to be dealing with mitral stenosis or mitral regurgitation. Okay, especially mitral stenosis. Right. Then when you feel the pulse, if you feel a high volume collapsing pulse and also very hyperdynamic circle, එදා දිහා බැලුවම ඕක පේනවා. Pulse එක කොහොම ගහනවා. You can see this carotid pulse like that. Very bounding pulses, even the dorsalis speed. So this is another trick. If you can feel a dorsalis pedis pulse, that's a hyperdynamic or high volume pulse. Okay, well, that's the most distal pulse. සාමාන්‍යයෙන් එච්චර හොඳට අහුවෙන්නෙම නැති pulse එකක්. But if you feel it, that you are damn sure it is a hyperdynamic pulse. Okay, and a high volume pulse. So if you feel a high volume collapsing pulse, okay, and a very hyperdynamic circulation like that, you know you are dealing with aortic regurgitation. ඇයි මේ aortic regurgitation එකේ collapsing pulse එන්නේ? Because in aortic regurgitation, blood is gushing into the aorta. Gushing into the aorta කියන්නේ there is a peak wave like that. So blood gushing into the, and there's a peak wave like that. Okay. Then what happens? Because of the regurgitation, what happens to that blood? It suddenly comes right back in. So ඇතුළට ගියා, in the next minute it goes right back the other way. So in other words, you get a very high pulse and then it collapses. Okay, it suddenly collapses. Why? Because all the blood that gushes into the aorta, in the next second or millisecond, it just goes back. So if I demonstrate this, it goes up and then whoosh down. So that's a collapsing pulse. So if you find a bounding, collapsing peripheral pulse in a very sort of hyperdynamic circulation, the patient almost always has aortic regurgitation. And there is another way that you can actually assess this blood going patas into the aorta and coming back in. Why? Because it is also going to be reflected in the blood pressure of the patient. මතක නේද? What do you check? Blood gushing into the aorta is, what is that? It is the systolic blood pressure. Blood gushing out of the aorta is the diastolic blood pressure. So what happens is the diastolic pressure starts dropping very rapidly, and they get a wide pulse pressure. So write that down. In aortic regurgitation, the patient gets a wide pulse pressure. And specifically with තරුවක් දාලා ලියා ගන්න, if you're writing this down, wide pulse pressure කියන්නේ the pulse pressure is larger than the diastolic pressure. Write that down very, very clearly. The pulse pressure is larger than the diastolic pressure. Now usually pulse pressure is 120, 80 kilowatt, it's 40. But in aortic regurgitation, it will be something like 120, 20. 120, 20. Pulse pressure is 100, but the diastolic pressure is 20. So the pulse pressure is wider or larger than the diastolic pressure. Very important, write that down. Right? So very nicely you can see this. Blood gushing in, blood gushing out. A very good pulse, then suddenly it goes back. collapses. Collapses. Okay? Goes out, comes back. Goes out, comes back. So very, very hyperdynamic pulse. Collapsing pulse. Wide pulse pressure, which is larger than the diastolic pressure. Aortic regurgitation. There is no bloody doubt that the patient has aortic regurgitation. No bloody doubt. Alright? The other extreme of that is when you feel the pulse. Abhi me carotid එක අහුවෙනවා අල්ලනවා අහුවෙන්නේ. Right? Peripheral pulses you can't feel anyway. And very low volume, difficult to feel. Right? And it is slow rising. Slow rising. Okay? Slow rising. It is probably something like this. Okay? Slow rising. Slow rising. Slow rising ගැන උඹලා මේ දවස් ඉතින් වෙන වැඩක් නැහැ ජිම් එකට වගේ ගිහලා weights කරනවා නම් when you are trying to lift something ඔහොම උස්සන්නේ. So when there is aortic stenosis, what happens? The pulse cannot මෙහෙම බෑ. Right? අමාරුවෙන් තමයි උස්සන්නේ. So that's called a slow rising pulse. So usual pulse, very nicely you can feel this. Slow rising pulse, especially this is well felt in the carotid pulse, goes like that. It's like you're straining to lift that pressure across the aortic valve. And also a very key feature is you get a carotid thrill in this condition. Carotid thrill කියන්නේ you feel a gush of blood under your fingers. So ඔය set එක හම්බුනොත් ළමයි you can be damn well sure that the patient has aortic stenosis. Narrow aortic valve, the pulse will be low volume, okay? It will be a slow rising pulse, and also there will be a carotid thrill because of turbulence. If you find these features, you can be damn sure it is aortic stenosis. You don't need to auscultate the patient. The last one is what you call a jerky pulse. It is not very important. It's a bit difficult for you to identify. But generally what you have is, if it's a high volume pulse, but without collapsing pulse, the cause is mitral regurgitation. So jerky pulse කියන එක කපා ගන්නව ලියන්න එපා. You say high volume pulse without collapsing pulse would be mitral regurgitation. Why do you get a high volume pulse in mitral regurgitation? Because of the volume overload. Volume overload. Okay. So very simple. From the pulse itself, we have diagnosed several conditions now. If you find a irregular pulse, diagnosis is clear, mitral stenosis. If you find a very high volume, hyperdynamic pulse, wide pulse pressure, collapsing pulse, all of these signs, you know it's aortic regurgitation. Because blood is gushing out into the aorta and gushing back in because of the regurgitation. In aortic stenosis, because the aortic valve is narrow, it's straining to push blood across it. So low volume pulses and a slow rising pulse. You might feel a thrill in the carotid artery. If it's a jerky pulse, that is also referred to as a high volume but non-collapsing pulse, probably it is mitral regurgitation. Okay, and this I have given you some notes about a collapsing pulse. So please read that. Okay, so that's about the arterial pulse. Then you have the jugular venous pulse. Okay, and just know how to identify a elevated JVP. Okay. Hurry. So now we have already diagnosed with good certainty AS, AR and MS and maybe MR also, right, to a certain extent. Then we go to palpation. I have already described some of these things to you. In mitral stenosis, you know that the patient develops a very loud first heart sound. Why does that happen? Now look carefully at my hands. Now the left ventricle is, imagine it's being filled up with blood. What usually happens is the mitral valve leaflets float on this blood. The blood piranakota, the mitral valve leaflets just float, and come together. Right? Just float and come together. But in mitral stenosis, because the ventricular filling is compromised, what happens is, it suddenly has to snap shut. Okay? Because it can't float, because the blood flow into the ventricle is compromised. The valve leaflets can't float on the blood and gradually close. It should suddenly close. So that causes a very loud first heart sound because of the sudden close or snapping of the mitral valve leaflets. Okay? And that's what generates a tapping apex. As I described earlier, tapping apex is a palpable first heart sound in the mitral area. Okay? Palpable first heart sound in the mitral area. Okay. Now we move on to mitral regurgitation. Now in mitral regurgitation, what you have is blood regurgitating across the mitral valve. But with time, what happens? This causes a vicious cycle of volume overload into the left ventricle. Then every single time a little bit of blood is regurgitated from the ventricle. The blood that was regurgitated comes back in the next cycle. So, what happens is there is a progressive volume overload of the left ventricle. So, the left ventricle becomes progressively volume overload because all these are regurgitated of blood. It comes back again onto the left heart with every single cardiac cycle. So you get volume overload. And when you get volume overload of the left ventricle, it causes a thrusting apex. So write that down, thrusting apex. And as I described to you earlier, thrusting apex means a displaced and forceful cardiac apical impulse. It is non-sustained. So very important, remember, a thrusting apex, mitral regurgitation due to volume overload. So when you feel the apex, if it's in the axilla, for example, apex is so displaced, it is in the axilla and it is thrusting, you can feel it very, very forcefully. You know that the diagnosis has to be mitral regurgitation. Okay. Or it also could be oya condition ekama vena thawa ekak thamai. What is the other condition that can cause this? Aortic regurgitation. So if you have a thrusting apex, it could be either mitral regurgitation or aortic regurgitation because of the volume overload. Volume overload. In aortic stenosis, because the valve is very narrow, right, the left ventricle has to give a lot of force to push blood across it. Right? Lot of force to push blood across it. What happens is then the left weights what happens is then I can't show off my muscles are non-existent. So I'm not going to do that. But basically what happens is the left ventricle becomes hypertrophied. Okay. And then very forceful, very forceful. And that's basically what it causes. Remember, if you're trying to lift a weight now, it's like a major weight, lot of resistance across the valve. It causes a heaving apex, Oh. Thrusting apex, volume overload. Okay. Heaving apex is pressure overload. So write the word down. It is pressure overload. Pressure overload. And that is aortic stenosis. So heaving apex is a non-displaced, sustained, forceful apex. And if you find that, the patient very likely has aortic stenosis. Alright. Now putting all of that together. If you find a patient with irregular pulse and a tapping apex, what is the diagnosis? Now remember, we have not auscultated the patient. Tapping apex, irregular pulse, mitral stenosis. Why the tapping apex? Because a loud S1, because a valve has to close or bang shut. It can't float on the filling of the ventricle. Okay, because the ventricular filling is compromised in mitral stenosis. Number 2, very high volume pulses, wide pulse pressure, hyperdynamic circulation, right? Collapsing pulse, a displaced forceful apex or a thrusting apex. What is the diagnosis? Aortic regurgitation. Okay. Difficult to feel pulses, carotid thrill, okay? Slow rising pulses, sustained pulses, that is, and that with a heaving apex, diagnosis aortic stenosis. A high volume pulse but no collapsing pulse with a thrusting apex is mitral regurgitation. No stethoscope. Right. Then you feel for thrills, remember? Right. Again, very simple. If you feel a systolic thrill at the apex, the diagnosis is almost always mitral regurgitation. Systolic thrill at the apex, diagnosis almost all right. These are called pearls of cardiology. Right? Right. Pearls before swine killer. Don't make that happen. So basically, number 1, if there is a thrill in the apex, that is a systolic thrill, it is mitral regurgitation. If you feel a systolic thrill in the left lower sternal edge, the diagnosis is almost always ventricular septal defect. Okay, diagnosis almost always ventricular septal defect. If you feel a thrill in the pulmonary area, the diagnosis is almost always pulmonary stenosis. And we have already discussed, if you feel a parasternal heave, that is just evidence of right ventricular hypertrophy. Okay. Now remember, we are adding, we are adding as we go to our diagnosis. Fine. So very simple, we have diagnosed almost all the conditions without auscultation. The monodapy kalla tiyenne, just revision now. If the patient is cyanosed, we are very happy. Why? 50% chance of getting it right. Cyanosis could be due to Eisenmenger syndrome or tetralogy of Fallot. What differentiates that is Eisenmenger syndrome, the driver is pulmonary hypertension. So you get full-blown kana pulmonary hypertension in Eisenmenger syndrome. Palpable second heart sound, elevated JVP, parasternal. If you have cyanosis without pulmonary hypertension, murmurs, diagnosis is tetralogy of Fallot. You might feel a pulmonary stenosis thrill and a murmur there as well. Fine. Cyanosis rare. By when we are still not using the stethoscope. Mitral stenosis, we can easily diagnose with irregularity of the pulse. Irregular AF is very likely it's MS. And MS tapping apex. Easy. If you see the pulse, peripheral pulses all are bounding, hyperdynamic, collapsing pulse, right? And wide pulse pressure. That coupled with a displaced forceful apex or a thrusting apex due to volume overload, sure aortic regurgitation. When aortic stenosis, peripheral pulses are very weak, slow rising pulse, carotid thrill, okay? A heaving apex beat. You don't need to auscultate. Aortic stenosis. Mitral regurgitation. Peripheral pulses are very prominent. Okay? Peripheral pulses are very prominent, but there is no collapsing pulse. Apex is significantly displaced. You might feel a thrill in that area. Apical thrill. Then, no doubt, the diagnosis is mitral regurgitation. If you feel a thrill in the left lower sternal edge, it is almost always PSD. ASD, if you don't find anything significant up to auscultation in the pulse or precordium or anything, it is probably ASD. It's not a very good way of differentiating it, I know. But ASTs generally are rare and you don't get them for the exam as well. Okay, so that is a rule in our department. We usually don't give ASTs for medical students at exams. So by then, now to add a little bit more, I want all of you to, for homework, look at a video of something called a CV wave in the jugular venous pressure. A CV wave, and look at a video on YouTube. Unfortunately, this video in this presentation doesn't seem to work. Our JVP elevated video CV wave. If you, that is the most important physical sign of tricuspid regurgitation, not the auscultation. Okay, CV wave is the most important point of tricuspid regurgitation. Right. Okay. Now, because it's not nice to end this without talking about auscultation, I will do auscultation, but remember, you don't need it now. I have diagnosed or shown you how to diagnose all the cardiovascular conditions without using your stethoscope. දැන් පොරවල් වගේ ස්ටෙතොස්කෝප් එක නැතුව අම්මරු මේක අල්ලපු ගමන් කියන්න පුළුවන් අපට මොකක්ද කියලා එහෙම කියාගෙන කෙල්ලොන්ට එහෙම වැඩ පාට දාන්න පුළුවන්. Especially if you are interested in teaching up with a junior batch person, then you can show off your skills. මට නංගි වල සෙට් එකක් නැතුව මේක diagnose කරන්න පුළුවන් කියලා you can basically go now. Right? But obviously cardiovascular system examination lecture would not be complete without auscultation, so I am just going to revise that as well. Alright. What are the physical signs of mitral stenosis? Very simple. The murmur is best heard in the mitral area, obviously. It is a low-pitched rumbling. Low-pitched rumbling mid-diastolic murmur. Low-pitched rumbling mid-diastolic murmur with pre-systolic accentuation. Okay, systolic when murmur එක අන්තිම හරිය it gets a bit louder. Why is that? Because of the atrial contraction at the last minute. And the first start sound is loud. Okay, ඒක ඇහෙන්නේ හරියටම මේ වගේ. Rup tuck. Rup tuck. Okay, that's exactly how you hear it. Rup is the rumbling, low-pitched mid-diastolic murmur. Rup tuck. The last part of the murmur is increased because of atrial contraction, and that is called pre-systolic accentuation. ඒකයි බයි AF තියෙන patient ලගේ එන්නේ නැහැ. Because in AF, do you get effective atrial contraction? No, you don't. It's just a shaking of the atrium like that. You don't get a good contraction. So rup tuck, rup tuck. Usually when I'm doing this lecture, I get people to sing with this, but obviously don't try to do that on Zoom. It will crash the thing. Okay, so rup tuck, rup tuck. The tuck is the loud first start sound. Why does it occur? Remember, it calls the tapping apex also. It is because of the valve leaflet snapping or closing shut. Because it cannot float up. It has to suddenly snap shut because there is no blood in the left ventricle because of the stenosis. So rumbling low-pitched mid-diastolic murmur, best heard in the apex. It may radiate to the axilla as well. May radiate to the axilla as well. And best heard in the left lateral position. Mitral regurgitation, very easy. The commonest murmur that you will listen to. It's a pan-systolic murmur. Best heard in the apex, radiates to the axilla. In most cases, it may radiate to the left lower sternal edge also. So in most cases, radiates to the axilla. In some cases, radiates to the left lower sternal edge. If the posterior leaflet of the mitral valve is involved. So write that down. That may be important when you come to a professoriate. We will discuss that a little bit more in detail. Okay. So pansystolic murmur, apex radiating to the axilla. Okay. may radiate to the left lower sternal edge, but that is only if the posterior mitral leaflet is involved. Usually it's the anterior leaflet. It moves to the axilla. Otherwise, it radiates to the left lower sternal edge. And it sounds like this. Okay, sounds like that. It's a long murmur. Aortic stenosis is an ejection or a short systolic murmur in the aortic area, radiating to the carotid. Remember, radiation you have to hear it in the same intensity, radiating to the carotids. Short systolic murmur. The MR sounds like that. Aortic stenosis sounds like okay. There is another sound which is a bit different. I'll teach that later. Hi. Aortic regurgitation is an early diastolic murmur, best heard in this area. I'll show that to you. The aortic regurgitation murmur is best heard in something called the sash area. Sash area kiyanne aortic area to the left mid-sternal edge. Sash කියන එක දන්නව නේද? Sash is basically අර band එක දාන්නේ මෙහෙම, right? So that's called the sash. Okay, this by the way is a scarf, right? So sash is, you can hear it in this area, from the aortic area to the mid left sternal edge. So it's heard best in this sash area. It is a early diastolic murmur. Early diastolic murmur. ඕක ඇහෙන්නේ මෙන්න මෙහෙම. It's like an expiratory sound. ඒ වගේ තමයි. Okay? So that's aortic regurgitation. Then බලමු ආයි. Mitral stenosis. Rup tuck. Low pitch rumbling mid diastolic murmur in the mitral area, loudest one. Might have presystolic action. Mitral regurgitation. Mitral area radiating to the axilla, pansystolic murmur. Aortic stenosis. Ejection systolic murmur, aortic area radiating to carotids. Aortic regurgitation in the sash area, aortic area to mid-sternal edge. Okay, and that is due to, and that sounds like a very soft. And remember how you listen for it? I showed you a picture. Leaning forward, breath held in expiration. ASD එච්චර වැඩක් නෑ. Don't worry too much about that. But remember, it causes fixed splitting of the second heart sound. Remember that from your cardiovascular module. And VSD, basically the murmur is best heard in the left lower sternal. It's a very loud murmur. Heard all over the place, but underlying the word, it does not radiate. It does not radiate, but it's heard everywhere. The difference between radiation is you have to hear it in the same or almost the same intensity in another area. Make a හැමතැනම ඇහුණට it doesn't radiate. So VSD is a pansystolic murmur, left lower sternal edge. So this is just a summary of what we discussed. Just a summary of what we discussed. There are some additional things here that for your reference about oscillations. Hari. Okay. Now, මෙතන student activity කියලා ගත්තම සාමාන්‍යව කරනවා. දැන් ඉතින් මොබ්බි සිම්බල කරනවද නැත්නම් නිදිද මොනවා කරනවද කියලා මම දන්නේ නැහැ. But basically, now you have to do for homework a table. On the top columns, write the disease. MS, MR, AS, AR, ASD, VSD, කොහොම ගාලා ලියන්න. On this side, write inspection, pulse examination, JVP, precordial examination, inspection, palpation, auscultation. And for each, write down the points. I'm just going to take very, very quickly for summary. Mitral stenosis. Okay. Irregular pulse, tapping apex, rumbling low pitch mid diastolic murmur, the loudest one. Mitral regurgitation, bounding pulse but no collapsing pulse. Thrusting apex, displaced volume, overloaded apex, thrill in the mitral area with a pansystolic murmur radiating to the axilla. Aortic stenosis, difficult to feel, low volume pulses, slow rising pulse. Okay. Carotid thrill, heaving apex, right, with ejection systolic murmur in the aortic area radiating to the carotids. Aortic regurgitation, very bounding peripheral pulses, okay, collapsing pulse, high volume pulses, all of that, okay, with a volume overloaded apex, displaced forceful apex, and an early diastolic murmur in the sash area. Aortic stenosis, low volume pulses, aortic acute, right? Fine, that's fine. VSD, thrill in the lower left sternal edge, pansystolic murmur in the lower left sternal edge. ASD, kamathina, liyanna puluwan, but not very important. And please, this doesn't take 15 minutes. Dhammama karanna. When we finish this discussion, do it now. So so write down a table and mark these things in that. Okay. And remember how we went through all the physical signs of this. Okay. Cyanosis, how to interpret the differences between Eisenmenger and Toff, and then using the pulse, JVP, blood pressure, palpation, looking for thrills, how to diagnose each of these lesions without using auscultation. Then finally, we went through the auscultatory findings. Okay, auscultatory findings. Mitral stenosis, the murmur occurs due to flow across the mitral valve during diastole. So it is a mid-diastolic murmur, rumbling, low-pitched. Mitral regurgitation is during systole that the valve leaks back, and that is a pansystolic murmur radiating to the axilla. Aortic stenosis, it is due to ejection of blood into the aortic valve or across the aortic valve. So it's a ejection systolic murmur in the aortic area, radiating to the carotids. And aortic regurgitation, leaking of the aortic valve during diastole. So it is a early diastolic murmur in the aortic area and the sash area. VSD is a pansystolic murmur in the left lower sternal edge. All right. Okay, so that is it. And please write the table down and also look for on a video a CV wave. CV wave. Okay, I'll try to share a link with you on the classroom thing so that you can look at that. Okay, fine. Right. So please ask any questions if you have any on the interpretation of physical science. This class is extremely difficult to do without seeing you buggers in front of me, but we don't have any other reasonable alternative as well. So ask any questions if you have any. Okay. So yes, so if you get a diagnosis in while you are, so example, you find mitral regurgitation and that's it. Do you still have to complete auscultation by getting the patient to sit up and bend? That's a very good question. Because you are undergraduate medical students, we expect you to complete the routine. So I think I might have told this to you. If I not, listen. At an undergraduate level, the main objective of giving you marks or whatever is, or the proficiency that we expect from you is the perfect technique, complete routine. right? Perfect technique, complete routine, no shortcuts. So even if you don't find a murmur before that and make a diagnosis, you still have to complete the routine, and you get marks for completing the routine. Okay, and also don't worry if you can't make a diagnosis. If you have got your technique perfect, then you will still pass. Okay, you won't get a lot of marks, but you will still barely pass at least if you get your technique perfect but still get the diagnosis wrong. We'll talk about this a little bit more when you come to professorials, how your short cases are marked and so on. Purna, yes, you need to comment about the grading of the murmur, and please refer any standard textbook will give you how to grade a murmur. And grading is usually for systolic murmurs only. So how do you find if the JVP is elevated? Sajid, I told you you don't really need to measure the JVP. Ideally, you have to measure the JVP. But if you see the JVP become in the 45-degree angle, you can say that it's increased. You don't have to measure it. And undergraduate level, we are not very worried about the JVP because we find that medical students, even postgraduates and obviously some consultants also, including some cardiologists, don't know how to interpret the jugular venous pressure. Okay, so don't worry about it too much. If you can't interpret it, just if it's visible in the 45-degree angle, patient pushes in the 45-degree angle, then it is elevated kila kiyanna puluwa, right? But don't worry about interpretation. There are only a very few clinicians who know how to interpret the JVP. I can still remember when we were medical students doing our second appointment, we did it with Dr. Bandula Vijayasirivardhana. He was an excellent clinician, very strict person, but excellent clinician. He's now in the private sector. And he took a class for us on the jugular venous pressure for 2 hours. So it is a major section in medicine, but don't worry about it. There are lots of things you can say on JVP, but undergraduates, not very important, and only very few people, very good clinicians like Bandula Vijayasirivardhana, know about interpretation of the jugular venous pressure. Okay. Hi. So if there are no further questions, and obviously, passe prashna matak wunot, you can put it on the WhatsApp group. The WhatsApp group is intended for that. For you to ask questions. Ekapata matak wena parata prashna dana. Bulai prashna dana mohotima mata uttara denna puluwan කියන එක I can't just make sure, but I will answer them at some point. Okay. So any questions you have, you can post it on the group, the WhatsApp group, and everybody knows the question and it's be useful for everybody. Right. Okay, so tomorrow, similarly, we will do the respiratory system. Sarangan, is that okay?
Yes, sir. Yes, sir.
Right. The connection is okay. It doesn't break off or anything, neither?
No, sir.
Clear,
yes.
Okay. Yeah. Right. Tell me if it breaks off suddenly. Sometimes the internet connections can be unpredictable. So if it breaks off, just tell me.
Okay, sure.
Okay, right. Hari, then see you tomorrow then. Okay.